Hello students. Today we'll be studying dermatology in a little different way, as in we've discussed about major theoretical topics. So in this section I'm going to tell you that in case in your ward leaving or in a clinical case examination you are given a case of dermatology, then how do you deal with it? So one of the very important cases that you might receive in your dermatology exam is of psoriasis. So what history to take, what clinical features to look for, what tests to do, and what questions you can be asked in that particular case, that I'm going to discuss today. So I'll be discussing it more in a clinical way, a case presentation kind of a format. So I'm going to discuss psoriasis with you today. With psoriasis, you broadly are already aware that it's a chronic disorder, it is multifactorial, and it is an inflammatory disorder which basically involves hyperproliferation of keratinocytes. So we already know that there is hyperproliferation of keratinocytes that happens. There is some inflammation which is happening. There is a change in epidermal turnover time, and there is a vasodilatation or vascular involvement that you see. It is multifactorial. So there are environmental factors, genetic factors, immunological factors that is involved. So you broadly know about this. Now, how do I ask the question? What questions do I ask the patient? So the first step is in any clinical case discussion is what history would you take from the patient and what history would the patient give you? So in a case of psoriasis, the important history is that the patient would be telling you that I am getting red areas, I'm getting red patches. The patient may use any term. So I'm getting red patches or red areas which are very scaly. So patient would tell you that when I sleep and I wake up, there are scales on my bed, there are scales all over. So depending on how the intensity of psoriasis is, the patient would give history of scaling and prominent red areas on the body. And if it is an erythroderma where there is more than 90% of the body surface area involvement, then the patient would tell you that my whole body is red and it is scaling. Okay, so scaling and red areas are the predominant history that you get from the patient. Then you ask the patient whether there are any symptoms associated with it. So what symptoms would be there? Usually psoriasis is asymptomatic. So the patient will not give any history of itching, any pain or anything. Patient would say, I have no symptoms. The only problem is it doesn't look good. The scales keep coming off my skin. Then you take history of seasonal variation, that does it change with any season? So the patient will typically give you history here that yes, I see a winter exacerbation. So history of winter exacerbation. Symptoms asymptomatic, so no itching. So seasonal variation, symptoms. Then you will ask what sites are affected. So patient will typically give history of extensor involvement. There is usually extensor involvement, and then you ask the patient whether it is present on both sides of the body. So mostly yes, it is bilaterally symmetrical. Then additionally, you can have involvement of scalp. You can have involvement of nails. So when you're taking a history, you will ask specifically about these sites in psoriasis, whether there is involvement of scalp, whether there is involvement of nail. Then systemic involvement. So you will ask the history of joint involvement. So how will you ask that? You will ask whether you feel stiffness of the joint, whether you face any pain in the joints. And this would involve the interphalangeal joints, that can involve the knee. So you have to take specific joint involvement, which can be in the form of pain, tenderness, or even stiffness. Then you can ask the patient whether there is any nail involvement, whether do you see any changes in the nail. Then a very important history, that does any other family member has the similar condition. So family history of similar condition. Why does it become relevant? Because we all know that there is a genetic component to psoriasis, and if there is a family history, there is probably HLA-CW6 which is involved, and that is associated with early onset of the disease, more severe disease, and presence of family history. So if you get a family history, you can broadly make out that probably yes, the patient is going to have more severe disease, patient is a child or an early onset disease. right? So family history of the lesions. Then you will ask whether there are new lesions which are appearing at the site of trauma. So you can ask the patient that in case you scratch, or in case you get hurt, do you notice new lesions over there? And this is relevant because psoriasis shows Koebner's or Koebner's phenomena. So there will be no new lesions at the site of trauma. Then there is something called as reverse Koebner's, in which the patient tells you that at the site of trauma, the lesions actually clear out. So that is another history that you might get. So this is called as reverse Koebner's phenomena, where there is actual clearance of lesions following a trauma to the skin. So all these become important in history. Then psoriasis, as we all know, is associated with comorbidities. There is a psoriatic march that I told you, that the inflammation which is there in the psoriasis is not just limited to the skin. It goes to involve the systems of the body also. So when you're taking a history in psoriasis patient, you will ask for comorbidities. Are you suffering from any cardiovascular diseases? Are you suffering from diabetes? You cannot ask metabolic syndrome to the patient. So what relevant history you can ask? Is there a history of diabetes in self or in the family members? You can look for obesity. You can ask whether in your blood reports, have you ever found that there is dyslipidemia, increased cholesterol, increased triglycerides? You can ask that. You can inquire about body weight. You can inquire about height, and you can find out the BMI and whether there is high BMI. So all this can point towards metabolic syndrome. Then obviously presence of diabetes. Then psoriasis can be aggravated and can be a cause of mood disorders. So you can ask whether there is any relevant history, like do you feel withdrawn, do you feel depressed, do you feel socially, do you feel your social interactions are limited, because psoriasis is a psychological burden on the patient. So sometimes a patient who is a patient of psoriasis does not like to be with people because he feels, what will people think? There is scaling coming out of all his body, right? So mood disorders is another relevant history that you will take. Then Crohn's disease is also known to be associated with psoriasis. So you will ask the patient that whether you have any bowel issues, is there any alternative diarrhea and constipation that you're facing? So all these are relevant comorbidities that you need to rule out in a patient of psoriasis. Then we all know that there are trigger factors. So you have to ask about those trigger factors. Trauma, which we already talked about. Then if it is a child and you think that there is a possibility of guttate psoriasis, even if it is not guttate psoriasis, even normal psoriasis may be aggravated by infection. So you will take a history that did you suffer from any fever, any sore throat, in the recent past. So any history of prior infection. Then eliciting or a history for HIV. So you can ask for sexual behaviors. You can ask for any blood transfusion. So which can give you a clue that probably you have to rule out HIV in this case. This is especially relevant if you're dealing with severe pustular psoriasis. Okay, so HIV, streptococcus and staphylococcal infection. Then stress, we already talked about. Then alcohol. How much is the alcohol intake? How much is the smoking? How many packs of cigarette do you smoke? Or whether you are a non-smoker, non-alcoholic. That again is a relevant trigger factors. Then when you do a blood labs, you can talk about hypocalcemia, which is again a trigger factor. Then sunlight. Sunlight in most of the cases of psoriasis is beneficial, but in 10 to 20% of the cases, it may cause exacerbation. So you have to take that history, that whether sunlight aggravates your psoriasis or improves your psoriasis. It can also help in formulating a treatment plan. If the patient is in that 10 to 20% of category, you will not think of phototherapy for that patient. All right. So all these trigger factors. Then a very, very important trigger factor is drugs. We have studied that there are medications which can provocate or aggravate psoriasis. So when you're taking a history, if it is a patient with diabetes, with hypertension or any other metabolic component, you have to take down the list of drugs that the patient is taking and whether any of these drugs have been started recently, which has led to a flare-up of psoriasis, because medications per se can act as trigger for psoriasis. So this is a list of medicines which can act as trigger factors, and you should be ruling that out in the current history. It's not that a patient who's a hypertensive, taking beta blockers for 20 years, developed psoriasis in last 1 year and you stop beta blockers for the patient. No, you have to try to find out whether there is a temporal correlation to it. But all these drugs are known to aggravate psoriasis. So if you think that recently a beta blocker was added and following that patient noted a flare up in the psoriasis, then you will send the patient back to your physician and tell them to change his or her antihypertensives. Okay, so various drugs that you can cause psoriasis are beta blockers, lithiums, antimalarials, NSAIDs, ACE inhibitors, antibiotics, interferons. All of these, this is a long list, so you can keep your list handy with you. Then, what do you look for? This is all in history that you ask, okay? All the relevant points, personal history, family history, everything. Now coming to examination. So when you are examining a patient of psoriasis, what all do you see? The first is site. What are the sites which are involved? So what are my pointers towards psoriasis? There will be mostly extensor involvement. And what are the common sites? Elbows, knees, then scalp involvement, lumbosacral areas, even intergluteal clefts, they can be involved. Then palms and soles are involved commonly in psoriasis. Then you look for symmetry in psoriasis, especially if it is not just a single plaque psoriasis, it's more of a generalized psoriasis, you would see bilaterally symmetrical lesion. So bilateral symmetry is a feature of psoriasis. So when you're describing the lesion, you mention the site, you mention the symmetry, then color. Usually they have that red colored lesion because of the vasodilatation. So salmon red colored lesion is very typical of psoriasis. Then, how would you describe a plaque of psoriasis? So if you're given a patient and the examiner asks you to describe this lesion of psoriasis, so how do you do it? So you say it is a well demarcated erythematous indurated plaque with silvery white semi-adherent scales. So it's usually psoriasis, a plaque of psoriasis is always well demarcated. It is erythematous or red. It is indurated. If you feel it, it's thickened. And there is an overlying scaling. And what kind of scale is it? It's usually a silvery white semi-adherent scaling. Clear? So there are 3 cardinal features when we are talking about any psoriatic plaque. It will have erythema or redness. It will be indurated and there will be scaling. And scaling will be typically silvery white semi-adherent scaling. So this is how you define a plaque of psoriasis. And then you say that there are multiple plaques which are bilaterally symmetrically present over elbows, knees and whatever areas they are present. And then you would point out that there is a scalp involvement, and then we'll talk about nail findings. Okay, so this is how you examine or how you explain about a plaque of psoriasis, and then you talk about site, symmetry, or you can say there are numerous plaques which are present on these sites. They are bilaterally symmetrical. If I try to define a single plaque, it is a well demarcated erythematous indurated plaque with silvery white semi-adherent scaling. Okay, then there are few signs, there are few things that you might see in psoriatic plaque which you should be aware about. Like look at these plaques. So I can see a halo around most of these psoriatic lesions. So what is this? So if you see a halo around psoriatic plaques, this is called as ring of Warnoff. This is called as ring of Warnoff. Why is it? This is because of local inability to synthesize PGE2. Since there is local inability to synthesize PGE2, there is some amount of vasoconstriction around the plaques which gives rise to this halo around these psoriatic plaques. It is a very common thing that you observe. This is called as ring of Warnoff. So if your patient is showing a ring of Warnoff, you may be asked about it. So it's a halo-round psoriatic plaque, and this happens because of inability to synthesize PGE2. And what are the things that you can see? Koebner's phenomena. So what you can actually see that if a patient has scratched, you might see linear lesion which looks like psoriasis. So presence of Koebner's phenomena should be looked for and should be asked for in a patient of psoriasis. Okay, so you might examine the patient, you might see there are sites where you are seeing Koebner's phenomenon and you should be knowing about it. That if there is any trauma, then the lesions of similar morphology develop at the site of trauma. So presence of Koebner's phenomena is another important thing that you see in examination. Then you would be asked about the sign in psoriasis. What bedside test would you do? So the bedside test that you would do in a psoriasis patient is you would try to elicit Auspitz sign. You would try to elicit Auspitz sign. So what is it and how is it done? So there is a plaque of psoriasis like this. You take a scalpel, blunt end of scalpel. You take a blunt end of the scalpel and you start scraping the plaque. You start scraping the plaque like that. Remember, from the blunt end, not from the sharp end, you'll hurt the patient. So from the blunt end of the scalpel, there is scaling on a psoriatic plaque, you start to scrape it off. So what happens? The first thing that happens is you see an accentuation or increased scaling. What do I mean by that? So there is a plaque, there is a scaling, but as soon as you start scraping, you feel that there is much more scaling as was visible. So there is accentuation or increased scaling that you see. Like look at the image here. As soon as you start scraping, you see increased scaling here. This is the first step that you see. Then what do? You keep scraping, you keep scraping, you keep scraping. Eventually, you find a glistening red membrane, which is also called as Berkeley's membrane. Fine. So you see a glistening red membrane, also called as Berkeley's membrane. Then you keep scraping. If you keep scraping even after that, you notice pinpoint bleeding points. So the first step, you see increased scaling. The second step, you see a glistening red membrane, which is also called as Berkeley's membrane. And by third step, if you keep scraping, look at it, you see these pinpoint bleeding points. So these are the three stages. These are the three stages of Auspitz sign, right? So Auspitz sign is all of these three. The first step, which is accentuation or increased scaling, is also called as Grattage test. Don't get confused. The first step, where you just increase scaling, is also called as Grattage test. Okay, this happens because of increased keratinier interface. So you notice more scaling. Now when you keep scraping, even after that, you are kind of eroding the epidermis and you reach dermoepidermal junction or basement membrane zone, which appears as glistening red membrane. Now we all know what happens in psoriasis. There is vasodilatation, which is there just below the epidermis. In the dermal papilla, there are dilated blood vessels which are there. So if you further scrape this basement membrane zone, those dilated capillary loops in the dermal papilla, they appear as pinpoint bleeding points. So this is because of dilatation of capillary loops in dermal papilla. So if you're given a case of psoriasis, this is one test that you would have to elicit and you should be knowing all about. Okay, so this whole is called Auspitz sign. So Auspitz sign is whole of this. But if you ask me which is the most important step, it is this. Pinpoint bleeding points. If you just see increased scaling, that's called as Grittage test. Then you see glistening membrane and pinpoint bleeding points. So all three steps together form Auspitz sign. Now, sometimes Grittage test is also called as candle sign. It's like you are flaking off the candle. And this is also called as, the second step is also called as sign of last hot sun, which I don't think so no anybody's gonna ask you. Okay, so this is a bedside test about psoriasis which you should be knowing about. Auspitz sign, Grittage test, and what do each step imply. Clear? Then you should also be aware about what are the different types of psoriasis and how do you differentiate them. Suppose you're given a case of scalp psoriasis. So a patient comes to you, there is just erythema and scaling on the scalp. So you should know that there is an entity called as scalp psoriasis where you will have psoriatic plaques just on the scalp. So how will you differentiate it from seborrheic dermatitis? There also you can see some scaling. There also you can see some redness. In scalp psoriasis, the erythematous plaque would be crossing the midline and it will not be itchy. And there is no alopecia associated with psoriasis. Okay, so scalp psoriasis, important features, it crosses the midline, there is no itching, there is no alopecia. You see erythematous, similar erythematous indurated plaques on scalp also. And sometimes the scaling may be so severe, this is hardly given to you, so we'll not discuss in detail, but there is a variant called as pityriasis amiantaceae. Now, sometimes they may give you flexural psoriasis or they may ask you about inverse psoriasis. So, what is it? In inverse psoriasis, instead of the extensors that I told you, there is predominantly flexural involvement. But here, you would not see any scaling. You would see less induration. So, this is how my flexural or inverse psoriasis differs from my normal psoriasis. Look at the patches here. So, how do you differentiate it from other flexural disorders? So there will be again no itching. There will be no itching and it will be more of a chronic problem. More sites will be involved and ideally to diagnose a case of flexural or inverse psoriasis, you need a biopsy. Okay. Then palmoplantar psoriasis. So lesions may be present on the palms and soles. They may present with hyperkeratotic plaques with fissuring. Hyperkeratotic plaques with fissuring. Then nail involvement is again very, very important thing. You might be shown nails of a psoriasis patient and asked to describe or asked what is the most common feature that you see. So if you look at the nails, the most common feature that you see in a patient of nail psoriasis is pitting. And what is this pit like? It is coarse, deep and irregular. Coarse pits, deep pits and irregular pits. Okay, so they'll be coarse, deep and irregular. Then you would see this, there is dystrophy of the nails. There is yellowish discoloration which is because of subungual hyperkeratosis. Because of subungual hyperkeratosis, there may be yellowish discoloration of the nails. There may be dystrophy. Then what is this? This is the most specific finding that you may see in a patient of nail psoriasis. This is called as oil drop sign. Oil drop sign is the most specific finding that you might see. What is oil drop sign? It is this area of yellowish orange discoloration which is present proximal to my yellow area. So this is my subungual hyperkeratosis giving rise to yellowish discoloration. And just proximal to this area, I have a orangish yellowish patch or discoloration, which is proximal to the subungual hyperkeratosis, is oil drop sign. This is one of the most specific finding of nail psoriasis. So pitting is the most common and oil drop sign is the most specific finding. Okay, so if there is a patient of psoriasis, there may be these nail changes and you may be asked about them. Okay, and see here, sometimes you might see these dilated capillary loops. You may see these dilated capillary loops. Okay, then you would ask the patient about joint involvement. So in joint involvement, you should remember that the most common joint is distal interphalangeal joint. So you will specifically ask about this joint, that is there any pain, is there any stiffness that you notice in this particular joint. But you should be knowing that according to Moll's and Wright classification, there are different patterns. And so there can be different joints involvement also. There can be knee involvement also. There can be ankle involvement also. So you should be broadly talking about all the joints that are involved. But yes, the most common would be DIP. But there can be spinal cord involvement, there can be DIP involvement, there can be symmetrical polyarthritis. So you should be broadly aware that there can be different types of joint involvement that can happen. But the most common is asymmetric oligoarthritis. This is the most common. And the most common joint is distal interphalangeal joint, which you should be asking to in the patient. Then on clinical examination, if there is severe joint involvement, what do you see? You see these sausage-shaped digits. See? These are all sausage-shaped digits that you see. Because their joints, there is new bone formation, there is thickening, there is fusion of the joints. So different internal joint changes that are leading to can present with sausage digits in the patient of psoriasis. So if you are shown a patient of psoriasis, the hands are seen and you see these sausage-shaped digits, you know that there is an underlying joint involvement which is there, right? And then you can be asked about the relevant radiographic evidence that you might see. So you should be knowing that there are two main radiological evidence for your sake. So if you do an X-ray of these sausage digit, you might see penicillin cup deformity or ivory phalanx. So penicillin cup is something like this. So see here, there is erosion of the bone which is happening, and then there is new bone formation which leads to penicillin cup deformity, or there can be new bone formation leading to dense phalanges which is called as ivory phalanx because of the new bone formation which is there. Okay, then to complete the examination, you ask about mucosal involvement, which is usually not there, except for in some cases of psoriatic arthritis, there may be uveitis which may be present, so you can take that history. So if a patient has joint involvement, you also ask that is there any irritation in the eye, is there any redness in the eye that they face. Otherwise, usually the mucosa is not involved in a patient of psoriasis. Then sometimes you may be given a patient of psoriasis who is presenting like this. You do not see a classical erythematous, indurated, scaly plaque. What you are seeing is multiple small erythematous plaques which are present in raindrop distribution. So you know that this may be a patient of guttate psoriasis. So how do I figure out that whether this is guttate psoriasis? So usually it would be a child. If you have taken your history, there would be a history of prior sore throat. And patient would tell you that there has been sudden appearance of multiple erythematous lesions, which are usually less scaly than my normal psoriasis. They are less scaly, but they are numerous, and they have a typical raindrop appearance, as if raindrops have fallen on the body. So multiple small lesions. So this is very, very important. Sometimes they give you a patient of guttate psoriasis. So it would be usually a child, there will be history of sore throat, and there will be multiple numerous erythematous lesions, which are usually sudden onset, like 2 weeks history, that's it. And then they ask you a very important question here. How do you treat these patients? So these patients are treated usually with antibiotics. And they usually clear up just with antibiotics. And what test you can do? You can do a throat swab and ASLO to find out an underlying streptococcal infection. Okay, so this is what you need to know about guttate psoriasis. So if a patient of guttate psoriasis is given, you should know about these important features. Then you should broadly know what is erythrotomic psoriasis, that there is more than 90% involvement, there is a lot of erythema, there is a lot of scaling. Then this is another variant of psoriasis that may be given to you, where you see lakes of pus. So you see these erythematous plaques, and then you notice numerous small pustules with formation of lakes of pus. So look at the lesions here. So they are small pustules, and at places they are forming these lakes of pus. So you know this is a case of pustular psoriasis. Pustular psoriasis. So this is another morphological variant. Okay. And here I usually give acitretin or methotrexate. Okay, clear? So this is another important variant that you should be aware about. Then they may ask you that is there a variant of pustular psoriasis in pregnancy? So you should know that impetigo herpetiformis is a variant of pustular psoriasis that you see in pregnancy. So if it is a pregnant patient who is presenting with pustular psoriasis, you know this is called as impetigo herpetiformis. So pustular psoriasis of pregnancy. So again, here you will see erythematous plaques beginning around the umbilicus, and you see these pustular lesions with lakes of pus, seen usually in third trimester. And here, the very important question that would be asked you is, what is my treatment of choice? So this is the only condition where you will give steroids as answer, oral steroids. There is no other psoriasis where you give oral steroids, but in pustular psoriasis of pregnancy or impetigo herpetiformis, you treat the patient with oral steroids. Okay, so these are the different morphological variants. Histopathology, I'll just walk you through it because they may ask you in Viva. You have to read about it in detail. It's more of theoretical thing, but you should be knowing that it shows parakeratosis. There is microabscesses of Monro. There is no granular layer. There is elongation of rete which is called as camel foot rete. Then there is suprapapillary thinning. There is spongiform pustules of Kogogs in stratum spinosum. There are dilated tortuous capillaries in the dermal papilla, and there is a superficial perivascular infiltrate. Now, histopathology may not be very relevant to you, but when it comes to a patient of psoriasis, everything becomes relevant to you. So even histopath becomes relevant. So look at the picture here. So after revising the different features, you know you are seeing nuclei in the stratum corneum. You know this is parakeratosis. And you see there is increased thickening of stratum corneum, so hyperkeratosis. You do not see any granular layer, so agranulosis. Then look at the stratum spinosum, so thickened, so you are seeing acanthosis. Then look at the rete ridges, they are so elongated. This is called as camel foot appearance. And then you see these suprapapillary thinning, infiltrate, dilated capillaries. And then there are two abscesses. Monro's microabscess that you see in stratum corneum, and spongiform pustules of Kogogs, which usually you see in stratum spinosum. Right? So histopathology of psoriasis, you should be knowing. There are a lot of MCQs and they can ask you in your clinical examination also. Treatment, So now then they will come to treatment, that what treatments are available. So I'll just walk you through the names. The details obviously is more of a theoretical part. So you should know that there are topical treatment, there are systemic treatment, and there is phototherapy. When do you give topical treatment? When there is less than 10% body surface area involvement, or if I do a psoriasis assessment severity scale, which is called as PASI, or psoriasis area severity index. So that you should not be knowing in detail, but you should know there is a scoring. So if that scoring is less than 10, if my body surface area is less than 10, I will give topical treatment to the patient. If it is more than 10%, if my PASI is more than 10, I will go for systemic therapies or phototherapies. In topical therapies, very, very important, you have to give emollients. You always need to talk about that I'll give emollients to the patient. Then the next choice of drug is corticosteroids. Then you give retinoids, vitamin D, coal tar, anthranilin, salicylic acid, and in face and flexures you give calcineurin inhibitors. Okay, all this is relevant. So you should be broadly able to tell what are the different topical therapies. Then phototherapy, there are two, NB-UVB and PUVA. What is the wavelength of NB-UVB? 311 to 313 nanometer, and this is the preferred mode because here you are not giving surveillance to the patient. Then in systemic therapy, you should be knowing there are three classes of drug which we broadly use. You can use methotrexate, you can use cyclosporin, and you use retinoids in the form of acitretin. So methotrexate, cyclosporin. Cyclosporin is more of a crisis drug. You do not use it for long term. If there is a patient who has severe psoriasis, you control the disease with cyclosporin and then you go to methotrexate and retinoids. Which retinoid do you use in psoriasis patient? You use acitretin. Isotretinoin you use in acne. Acitretin you use in psoriasis. And this is also my drug of choice in patients with pustular psoriasis, in patients with HIV and immunodeficiency. So they can ask you this. If I have a patient of HIV with psoriasis, my treatment of choice will become acitretin. Otherwise, my treatment of choice is methotrexate. My systemic therapy of choice is methotrexate. If it is an erythrodermic psoriasis, if PASI is more than 10, anything, it's methotrexate. But in cases of pustular psoriasis, HIV and immunodeficient individuals, I use acitretin. If it is a pregnant female with psoriasis, I use oral steroids. Right? Then they can ask you this, what are the newer agents that you use in psoriasis? So apremilast and tofacitinib, these are the two new agents which we are using in psoriasis these days. These are oral drugs. Apremilast is PDE4 inhibitors and tofacitinib is JAK kinase inhibitors. These are oral drugs that we are using in patients with psoriasis. Then broadly just know about that there are biologicals also which are used. This is more of a theoretical thing again, but they may ask what are the different options. So you should know that there are different biologicals which are being used for psoriasis, which target a specific immunopathogenetic pathway in the disease. They're not broad immunosuppressants, they target one particular pathway. Which is the common one that we use? We use secukinumab. So in this league of approach to a patient in the clinical, when we're talking about clinical cases, so I will be talking about approach to a patient with lichen planus. We talked about how do we approach a patient of psoriasis. Now I'll talk about how do we clinically approach when a patient of lichen planus comes to us. So before moving on, just a brief, what is lichen planus? It's a type of papilloscomus disorder which is autoimmune in nature. So autoimmune as in, here my T cells are acting against my own body, and T cells are acting against what antigen? This antigen can be either a self-peptide which is present in the body, or it can be some external agent. And what external agent can it be? It can be any drug, it can be any infection, any drug, or even a contact allergen. Infection, drug, or contact allergen. What are the common infections that we see associated with lichen planus? We see hepatitis B virus infection and hepatitis C virus infection. So whenever we are dealing with the patient of lichen planus, we take such history as to rule out these infections, rule out any drug involvement, and rule out the association with any contact allergen. So what do I ask my patient? So if I get a patient of lichen planus, the questions that I ask is, what are your symptoms? So in symptoms, patient would definitely tell me that there is itching. With psoriasis, I told you that the lesions are asymptomatic. Here, there would be itching. And then if you ask the patient, how do you itch? How do you itch? So the patient will characteristically tell you that he rubs, not scratches. So if you tell them to demonstrate that how do you itch, the patient would be rubbing. Patient does not scratch a lesion of lichen planus because scratching induces pain in these patients. So though they have itching, so to calm down their itching, they will always rub. They will not scratch, which is a very, very important symptom. Then you ask the patient, what are your sites which are affected? So when you are talking about sites, you typically have involvement of skin, mucosa, nail and hair. So you will ask history pertaining to all of this. So you will ask, do you have lesions on the skin? And in skin, what would be the common sites which will be involved? It would be flexures, typically wrists, elbow area. These are commonly involved. Then you ask history of mucosal involvement. How do you ask that? In the mucosa, oral mucosa, so you ask which mucosa is involved, any problems with the oral mucosa, genital mucosa, perianal mucosa. And typically in history, if the oral mucosa is involved, patient will give you a history that there is difficulty in eating hot, spicy food. So there is difficulty in eating hot, spicy food. This is a typical history that he'll give you. He'll say, I have difficulty when I eat hot and spicy food. Or you tell them you have difficulty in eating. They say yes. And so you ask specifically what kind of food causes difficulty. So here, typically hot, spicy food causes problems. Then you can inquire whether you have any genital lesions, any perianal lesions, any eye problems, or other mucosa you should be inquiring about. Then you ask the patient, do you see some changes on the nails? So what history can the patient give you? In the nails, patient may tell you that yes, my nails are roughened. My nails are roughened. Rough ho gaye nails. Because of longitudinal ridging that you see, the patient may give history of roughening of nails, dry nails, roughened nails. And in the hair, patient will give history that there is loss of hair. If hair are involved, patient will give you history that there are patches of hair loss. And they will give history that before these patches of hair loss, it was preceded by itching and some raised lesions on the scalp. So patient will typically give you all these history in a patient or in a case of lichen planus. Then you inquire further. You ask, are you on any particular drugs? So what are the common drugs you will inquire about? Did you take any antibiotics? Did you suffer from tuberculosis in the past? Do you have any history of blood pressure? Were you on antimalarials, anticonvulsants? For any reason were you given heavy metals like gold, lithium? Like these are given for psychiatric issues. So you can ask them that, do you suffer from any medical illness? And if they do, then what are the drugs they are taking? Because these drugs can predispose any patient of lichen planus, and these drugs per se can be a cause of LP-like lesions, which are called as lichenoid lesions in the body. So you take a history of drugs, which is called as treatment history, per se pertaining to the disease and per se pertaining to the cause of the disease. So are you on any medicines which might be related to this? So you have to ask them specifically, are you a known case of hypertension? Have you had any psychiatric consultations in the past? Had you had convulsions in the past? So this all becomes relevant. But remember, it's not like they had convulsions when they were a child and now they will be having lichen planus. So usually the duration is up to 8 weeks. Can be longer. Science, medical science is not a very cut-off thing. So can be longer, but usually the drugs have been taken in past 2 months. So you have to take a recent history. It's not like if they were, as a child, they had suffered from convulsions and then they had taken anticonvulsants which have been discontinued for many years, that now they'll be developing lichen planus. It is rare. So that temporal correlation, this is called as temporal correlation, is important. Right? Next. So then you take history. If the patient is giving history of oral lesions, then you always ask that have you undergone any dental procedure in the recent past? Have you got any filling done? Did you get any dental amalgams put in your teeth? And if there is a history, usually oral lichen planus can happen after use of dental amalgams, and you remove them and oral lichen planus improves. So you take the history of these dental amalgams. So this was about history. So in history, you inquire about skin, mucosa, hair, nail. You take the history of drugs. You take the history of dental amalgams. You also try to elicit if there is any sexual history which is relevant, because that may point towards hepatitis B or C infection. Right? And then we come to examination. So in examination, we examine each site one by one. So in the skin, we look for what is the sites which are affected. So you would usually see a flexural involvement, and again, these lesions would also be usually bilaterally symmetrical. So you would see flexural involvement and you would see bilateral symmetry of the lesion. And then what would be the morphology of the lesion? How would you describe any lesion of lichen planus? You would see that I see 5 P's. What are the 5 P's that I see? I see purplish, which can also be termed as violaceous, plain topped, polygonal, pruritic, papules. So you see bilaterally symmetrical, purplish, plain topped, polygonal, pruritic papules. So if you see these, this is how a patient of lichen planus would look like. And in this case, like, how will you describe? You would say, I see multiple purplish or violaceous papules which are polygonal in shape, which are plain topped, and which are present on the dorsal aspect of foot, and these are bilaterally symmetrical. So this is how you describe it. And then what else do you see in examination? So after doing this, after seeing this, see, pruritus is a feature which will be usually in the history. So just to make 5 P's, they've put pruritic here, but sometimes you can see scratch marks. But as I said, lichen planus patients usually do not scratch. That's why their surface is plain topped. Otherwise, you would see all scratch marks, but usually they do not scratch. They rub, and that is why the surface is plain topped. Then what else can you see? In the patient, you would look for Koebner's phenomena. Since the patient is itching, sometimes he may scratch, and there you might see these lesions along the lines of trauma. So positive Koebner's phenomena is also seen in lichen planus, where you would see LP-like lesions along the line of trauma. So you see lichen planus like lesions in the linear fashion along the line of trauma. So that you can also see in your patient. And then you would take a hand lens and look for Wickham's triae. What are Wickham's triae? So you look for Wickham's triae. How do you do that? You do it by using a hand lens. You can put a mineral oil or little oil on the surface of the lesion and then examine it under hand lens. And what you will see is, you would see whitish streaks on the surface of LP lesion. So what do you do? How do you see Wickham's triae? You put some mineral oil on the plaque of lichen planus. You take a hand lens and you examine it under that. You see these whitish streaks on the surface of the lesion. You may be asked, what is this whitish streak? This is nothing but hypergranulosis that you see on histopathology. So when we do about histopathology, in histopathology you should be knowing lichen planus is a condition where I see hypergranulosis, and this hypergranulosis may be clinically evident as Wickham's striae when I see it under hand lens by putting some mineral oil. Clear? So Wickham's striae and Koebner's phenomena are two things you would like to see in the skin LP. Then you would examine the oral mucosa of the patient. So remember, even if the patient is not giving you history of oral involvement, patient is not saying that he has any complaints, still you examine the oral mucosa, because sometimes these lesions, they may be just starting and so may be asymptomatic, or maybe on the posterior part of buccal mucosa, so patient may not be facing problem. But you always examine all mucosas, hair and nail in patient of lichen planus. So when you examine the oral mucosa, what can you see? You might see whitish, lacy, reticular pattern. You might see this. And what is the common site where you will see it? You will most commonly see it on buccal mucosa. But you also examine tongue, you also examine gingival mucosa. We examine all these sites. And what is the most common thing that you can see? You can see a whitish, lacy, reticular pattern which is present on the buccal mucosa. And do look at the posterior aspect. So this is how you might be able to see. And then look at here. So if you see something like this, you can see some dental amalgam sitting right there. So sometimes patient may not give you the history, but on examination you would be able to find, you would be able to see a dental amalgam, and you can counsel the patient accordingly. So when you are examining the oral mucosa, look for all these sites, look for this lacy reticular pattern, and then you also try to look for presence of any dental amalgams. Okay, then you might see some unusual variants. So you should know that lichen planus can lead to some unusual variants also in the oral mucosa or also on the body. So in oral mucosa, not just lacy reticular pattern, you might see ulcerations, you might see atrophic plaque. So all that is also seen in patients with oral lichen planus, and you should just be aware about it. Most commonly what you will get is a whitish lacy reticular pattern. Then what do you look in the nails? In the nails, you look for longitudinal ridging. What is longitudinal ridging? These longitudinal lines that you see on the nails. These longitudinal lines that you see in the nails. Then you would see that the nail plate is so rough. So rough surface of the nail plate. And nail plate would be thin. So all these findings you can see, and then you can be asked what is the most common finding. So longitudinal ridging is the most common finding of nail LP. Then they can ask you what is this called as. This is also called as trachyonychia or sandblasted nails. Then what is the other finding that you may see in the nails? You might see pterygium. You might see pterygium in the nail. What is pterygium? Pterygium is wing-shaped fold of proximal nail fold onto the nail plate. Okay, so this is how a pterygium looks like. That is the wing-shaped extension of the proximal nail fold onto the nail plate. This pterygium is a very, very specific finding of lichen planus. Okay, so you should look at the nails, you should try to find longitudinal ridging, pterygium, or anything that you can see. Maybe you just see rough nails, you may see just thinning of the nail plate. So all this can be there. Sometimes there may be even tenting of the nail plate. Tenting of the nail plate. So all these findings you can see in the nails. Then you examine the hair of the patient and you look for any, what can you see? You might see follicular violaceous papules. So in the beginning you would see just violaceous papules, and then you might even see areas of cicatricial or scarring alopecia. So you see areas of cicatricial or scarring alopecia, and you see follicular violaceous papules. So what is scarring alopecia? You would see that there is complete loss of hair, and there are no hair follicles or hair roots that you can see there. That means there is a permanent damage which has been caused. Okay, so you examine all these sites. Histopath is usually not important for clinical diagnosis, but broadly you should know what do you see in histopath. In stratum corneum, look at the stratum corneum, you see hyperkeratosis. In stratum granulosum, you see this. You see focal, wedge-shaped hypergranulosis. You see hypergranulosis, which is focal and wedge-shaped. Then you see acanthosis. And what is the most important feature of lichen planus? That it causes basement membrane zone destruction. So what happens? My basal cell, they are degenerated, and there is a band-like infiltrate which is present on the just below the DE junction. So there is a basement membrane zone destruction. So you see this is the basement membrane where you see basal cells which are degenerated, and there is a band-like infiltrate which is present just below it. There are other features, but for clinical examination, usually they are not important. What else you can see? You can see colloid or civet bodies, you can see pigmentary incontinence, and they can ask you what is the shape of rete ridges. So it is sawtooth rete ridges. All this you will read in more details in the theoretical classes. Okay, but broadly, these are the features which you should be knowing, and you should definitely be knowing in lichen planus, my T cells, they target the basement membrane zone. So the main pathology is there is basal cell degeneration, and there is a band-like infiltrate which is present. There is a band-like infiltrate which is present. And the next question would be, how would you treat such a patient? So in treatment, broadly, again, there are 3 ways to treat. If it is a localized kind of a problem, you can give topical treatment in which you can use corticosteroids. And if it is present on the face or flexures, you would say calcineurin inhibitors, right? Then if it is in the oral mucosa, you would say that I would give topical anesthetic agents, because how will the patient eat, right? Then if the disease is extensive, you might need oral treatment. And what oral treatment you can give? You can give corticosteroids, you can give dapsone, you can give methotrexate, acitretin, you can give HCQS. So remember, HCQS also leads to lichen planus, but it is also used in treatment of lichen planus. Then if it is a child with extensive disease, you can also think about or give an option of phototherapy. What kind of phototherapy do you use? We use NBV UV therapy. So especially in child with extensive disease. Most important, you will definitely add antihistamines. You will say this, that I would like to give antihistamines because the patient is itchy. And the last thing, counseling. So whenever at your stage, if we are talking about the management, remember, rather than these drugs, it is these sidey things, these adjunctive things which are more important. You should be talking about antihistamines. You should be talking about counseling the patient that this is a chronic disease. It may remit. So remission is a possibility. And then if there is hair involvement, you counsel that these hairs are permanently gone. We are giving you treatment to prevent further damage. But you have to counsel that this is a scarring kind of alopecia. Okay, so this is how you would approach a patient of lichen planus in a clinical setting. Okay, thank you.